Let's get started with Cardiovascular 11. First question, what are the four important pharmacokinetic equations? So the first one is volume of distribution equals the amount of drug given in IV form divided by the concentration of that drug in plasma, or volume of distribution equals D over C. The second equation is for clearance. Clearance equals 0.7 times the volume of distribution divided by the half-life. The third equation was for the loading dose. So loading dose is equal to the concentration at steady state, or the desired plasma concentration, times the volume of distribution. And the last one is maintenance dose equals the concentration at steady state times clearance. All right, time for the lecture.
Welcome to our Step 1 video on antiarrhythmics. Please don't get this confused with the 1980s band, the Eurythmics. We will not be finding out what dreams are made of. Neither will we travel the world or the seven seas. Everyone is looking for something, and yes, some of them will want to use you, and some of them will want to get used by you. But really, guys, you need to hold your head up. Keep that head up. And now, we're moving on. All right, so in another video, we talked about the electrophysiology of the heart, and we looked at those fantastic action potentials of the myocytes and the pacemaker cells. So in this lecture, we're going to take that knowledge and then start talking about the antiarrhythmic medications. Now, some of you might be saying, but wait, Dr. Lewis, shouldn't we talk about arrhythmias before we talk about antiarrhythmic drugs? And then I would just ignore you and keep moving on. Just kidding. Now, I like to teach it in this order because we just talked about how those ion channels are critical to the action potentials in the heart. These drugs work on those channels, so it makes a lot more sense to cover this now while it's fresh in your mind. Now, we will discuss which arrhythmias these will treat, but don't panic, we'll cover those in detail in other lectures. So, there are four different classes of antiarrhythmics, and there are several mnemonics. Now, one mnemonic is no bad boy keeps clean. So, the no is for sodium channel blockers, which is class 1. Bad boy is for class 2, those beta blockers. Keeps, is the K there is for potassium, so these are your potassium channel blockers, the class 3s. And then the clean is for calcium channel blockers, your class 4 antiarrhythmics. Now another mnemonic that we've had several students write in about is some block potassium channels. That one is actually a bit more specific. I kind of like this one. Some is for sodium, block is for beta blockers, potassium is for potassium, and then the channels is going to be for calcium channel blockers. So use whichever one is easiest for you to remember. So let's go through these by class. So first we have the sodium channel blockers. So all class 1 drugs are going to decrease the slope of phase 0. And by decreasing the slope of phase 0, you are elongating the effective refractory period. Now what happened at phase 0 in the myocyte? Well, in myocytes, phase 0 was when sodium channels opened, which caused that depolarization. Okay, so that's how these sodium channel blockers work. Now the different classes of these sodium channel blockers, class 1A, 1B, 1C, have different effects on phase 3. I don't really want you to worry too much about the phase 3 effect in these drugs. The main effect, again, is that these are sodium channel blockers and they're working on 0 phase primarily. All right, so let's talk about your different classes of those sodium channel blockers and where we might use them. So first we have quinidine and procainamide, and also disopyramide as well. Those are the class 1A. Lidocaine, mexiletine, and toconide, those are class 1B. And then flecainide and propafenone, those are 1C. Now, it is worthwhile to know which of these drugs is going to fall into those different categories, and there are a few mnemonics, again, that can help you with this. So 1A is the double quarter pounders. Class 1B is going to be the mayo, lettuce, and tomato, so that's the inside of the burger. And then class 1C is fries, please, so that's the side. So to help you remember how to divide these up, remember the burger, the insides of the burger, and then a side. But use whatever mnemonic works for you. So let's go down the list here. Class 1A, we're going to talk about a few of these drugs in particular. So class 1A, remember it was procainamide, quinidine, and disopyramide. So these will increase action potential duration, effective refractory period, and that QT interval. Now the two things I want you to know about procainamide is that it's used for Wolff-Parkinson-White. And Wolff-Parkinson-White is pretty much the only time you're ever going to see procainamide being used. And then the number 2 thing about procainamide is that it can cause reversible SLE-like syndrome, so drug-induced lupus. Now there's a mnemonic, SHIP, S-H-I-P-P, for drug-induced lupus. Well, one of the P's was for procainamide. procainamide. So procainamide can cause that drug-induced lupus. Now phenytoin was the other P in that mnemonic. And now technically it is a sodium channel blocker, but it is not an antiarrhythmic, so we're not actually going to talk about it here. Next we have quinidine. Don't confuse quinidine with quinine. Remember that quinine is an anti-malarial drug. Quinidine is the antiarrhythmic. Now quinidine can cause synconism. That's the important thing to remember on this one. What is synconism? So it's headache, dizziness, and tinnitus. Quinidine can also cause thrombocytopenia, and it can also cause torsades de pointe due to increased QT interval. And most all of these antiarrhythmics can cause arrhythmias, which is a bit ironic. So you have to be very judicious with your use of any antiarrhythmic. Now you may notice that some books include amiodarone in the 1A sodium channel blocker group. Amiodarone does act on sodium channels, but it's probably better recognized as a potassium channel blocker. Therefore, we'll save our discussion on amiodarone until we get to that section. Let's move on to class 1B. 1B probably a little more often used. This includes lidocaine, toconide, and mexiletine. That's the mayo, lettuce, and tomato. Now lidocaine is probably the most commonly used out of these. It's useful for acute ventricular tachyarrhythmias. It's beneficial because it slows the heart rate down pretty dramatically. Lidocaine also used in digitalis-induced arrhythmias. So lidocaine is used for those tachyarrhythmias, especially after an MI. So a patient has an MI, develops a tachyarrhythmia, they're not doing so well, like ventricular tachycardia, you might consider using lidocaine for that acute situation. The toxicity of these drugs can be worse in the setting of hyperkalemia, so remember that as well. And finally, we have the 1C class. Not as commonly used, though I do see flecainide being used more and more nowadays. Propafenone I don't see being used much at all. Fries, please, is the mnemonic here to remember. Now they're used in ventricular tachycardia progressing to VFib, so these patients are not doing well. They are the last resort in ventricular arrhythmias in general. Class 1C drugs are pro-arrhythmic, as we've already said before about the other ones, especially in the post-MI state. And again, the toxicity is going to be worse in the setting of hyperkalemia again as well. Now there is one more drug I want you to know about. It doesn't fit in these categories very nicely at all. The drug is ivabradine. Now it inhibits the funny sodium channel. So funny sodium channels are named this because they are permeable to both sodium and potassium and are classified as 1F channels. Now when you block these channels, then we see a prolongation of phase 4, which will decrease SA node firing. Now ivabradine is used in chronic stable angina, especially in patients that maybe don't tolerate beta blockers, and they can also be used in patients with chronic heart failure. Adverse side effects are kind of interesting, include hypertension, bradycardia. That's not very interesting. But what is interesting is what's called the luminous phenomena. So that's where a patient kind of describes their vision being overly bright. So I think that's interesting. Next class, beta blockers. These are the bad boys. So the beta blockers like to end in olol, like propranolol, esmolol, metoprolol, atenolol, timolol. There's a lot of alls out there. So the mechanism is that they decrease cyclic AMP, and they're going to decrease calcium currents as well. So they increase the PR interval and suppress abnormal pacemakers, especially the AV node. So how do they work? Well, they suppress abnormal pacemakers by decreasing the slope of phase 4. So remember phase 4 in beta blockers. Decreasing the slope of phase 4 is going to slow down the heart rate generally. So remember that what we saw in our phase 4 of the pacemaker cell, there's a gradual increase in charge caused by the gradual opening of sodium channels that ultimately lead to a depolarization. Beta blockers are going to flatten out that phase 4 some, which prolongs the frequency of those depolarizations. Now, the clinical uses of beta blockers include things like coronary artery disease, hypertension, SVT, slowing ventricular rate down during AFib as well if you're going to do a rate control, and also A-flutter as well, you might use beta blockers. Beta blockers do have some adverse reactions that are high yield. They include exacerbations of asthma, also bradycardia. AV block can get worse with these, CHF exacerbation. Also remember that beta blockers can mask the effects of hypoglycemia, so be careful with your diabetic patients. Now the treatment for beta blocker overdose is glucagon. Moving on to our potassium channel blockers. These are the class 3 drugs. Potassium channel blockers are working at phase 3, so that's easy, class 3, phase 3. It slows down the release of potassium, thereby elongating the effective refractory period. These drugs increase the action potential duration and the QT interval. These include things like sotalol. Don't be confused there. Sotalol kind of looks like a beta blocker, but it's actually not. Ibutylide, beryllium, dofetilide, and amiodarone. Those are the potassium blockers here. Now, the two most commonly used are going to be sotalol and amiodarone. Both of these are commonly used for rhythm control in patients with atrial fibrillation. Amiodarone also used for Wolff-Parkinson-White syndrome. So we've mentioned two drugs now that can be used for WPW, procainamide and amiodarone. Probably more important for your test is the toxicity of these drugs, specifically amiodarone. Torsades de pointe is an important adverse reaction to remember with all the potassium channel blockers, but I do want to spend a little extra time with amiodarone. Amiodarone can cause pulmonary fibrosis, hepatotoxicity, hypo or hyperthyroidism. So remember to check your PFTs, your LFTs, and your TFTs when using amiodarone. Now, why does amiodarone cause hypo or hyperthyroidism? Amiodarone is actually 40% iodine by weight, and the only tissue in your body that uses iodine is your thyroid. Now, amiodarone can cause a lot of other things: corneal deposits, skin deposits resulting in photodermatitis. Remember your mnemonic SAT for photo. The SAT stood for sulfonamides, amiodarone, and tetracycline, which can cause photosensitivity. Neurologic effects as well: constipation, cardiovascular effects like bradycardia, heart block, and heart failure. So it slows down the heart, which is why it works for rhythm control and atrial fibrillation. So to reiterate, your class 3 drugs, your potassium channel blockers, are working at phase 3. Easy to remember, phase 3, class 3. Phase 3 is the myocyte phase where potassium is leaving the cells. Now, these drugs slow down the release of potassium, thereby elongating that effective refractory period. So good memory tools there. Finally, let's move on to our calcium channel blockers. The calcium channel blockers include verapamil, diltiazem. Calcium channel blockers do come in two main categories. There's the dihydropyridine and the non-dihydropyridine calcium channel blockers. The non-dihydropyridine calcium channel blockers work primarily at the heart. And then the dihydropyridine, they do not work on the heart very much. They're more for blood pressure. So you do not see calcium channel blockers like nifedipine and amlodipine here, because nifedipine is that dihydropyridine. So how do the non-dihydropyridine drugs work? Well, calcium channel blockers decrease the slope of phase 0 of the pacemaker cells. So that's going to elongate that effective refractory period again. Now remember that calcium was the cause of the depolarization in the pacemaker action potential. Therefore, there is a decrease in conduction velocity of the AV node specifically when you give a calcium channel blocker to a patient. Toxicity: well, this can cause things like constipation, they can cause flushing, edema, that's a big one, lower extremity edema, cardiovascular effects like heart failure, AV block, sinus node depression, and even torsades de pointe again. So somebody that's in heart failure exacerbation, you would not want to use a lot of drugs like this because it could worsen that CHF. And then you're going to want to use caution in combining your calcium channel blockers like verapamil and diltiazem with other antiarrhythmics, especially beta blockers. Combining those two classes together can cause a more substantial heart block. So I bet you remember everything that we just covered. Yeah, me neither. Let's hit a Lewis Notes. All right, guys, welcome to another Lewis Notes, and we're looking at the wonderful world of antiarrhythmics. It can be a little bit tricky to know where each one of these drugs fits into their class, so we're going to go through those again because the more you do this, the more it's likely to stay into your brain. So let's get going here. We're going to take all of our green drugs here. We're going to put them into classes. So the first one we have here is propafenone. Propafenone is one of our 1C sodium channel blockers. We're going to put that one right over there. Next, we have propranolol. So olol should immediately make you think of bad boys or beta blockers. So we're going to put that right there. Quinidine. So quinidine is going to be our quarter pounder. So remember, quarter is going to go into our class 1A sodium channel blockers. Lidocaine is one of our 1B. That's our lettuce. Diltiazem is a calcium channel blocker. So calcium channel blockers are our class 4. Metoprolol is an olol again, so that should make you think of a beta blocker. Next we have sotalol. So should that go into the beta blockers? That one is tricky. This is actually an alol, so that's a good indication of where this should go, and it's going to go over here in our class 3, our potassium channel blockers. Disopyramide is the double in double quarter pounder, so we're going to put that over here in our class 1A. Mexilotine is our mayo in the inside of our burger, so that's going to be class 1B. Amiodarone, so it has actually a lot of actions. It's probably primarily recognized as a potassium channel blocker. It does have some sodium channel blockade as well. Verapamil is another calcium channel blocker. That's going to go over in our 4. Procainamide is going to be the pounder in our double quarter pounder in our class 1A. Tokanide is going to go over here. It's the tomato that's going to be over here in the class 1B again. And then our last one, flecainide. So flecainide is another class 1C drug. Now, one other thing I want to add on here is like where these drugs are acting when we're talking about the electrophysiology. So if we look at all of these class 1 drugs, these sodium channel blockers, remember they're working on phase 0. So phase 0, and that's going to be on the myocyte. So phase 1 on the myocyte is where those are going to act. If we look at our class 2 here, at class 2, we're looking at a phase 4. And it's prolonging that phase. In our class 3, we're looking at phase 3. That's where those are acting right here. Remember, class 3, phase 3. And then here again, with our class 4, we're working on phase 0 again. But it's not on the myocyte, it's on the pacemaker. So remember, it's on the pacemaker on our phase 4. That's a little bit different than our sodium channel blockers. All right, guys, so those are all the antiarrhythmics. I think if you know this stuff, you'll do well for your test. All right, so now let's move on to adenosine. So adenosine increases potassium leaving the cells, thereby hyperpolarizing the cell. Additionally, it decreases the permeability of the cell to calcium. So let's think about that for a second. If more potassium is leaving the cells, that's causing the cell's resting membrane potential to stay at the cell resting membrane potential. It's not moving. And if calcium can't trigger a depolarization of your SA and AV nodes, you're not going to depolarize. So this is exactly what happens with adenosine. You're causing flatlining. You cannot depolarize. So you push adenosine into somebody, you're going to stop that heart. So what can you do with this drug? Well, we use it for supraventricular tachycardias. So it can help both diagnose and then also treat SVT. Now, sometimes you see a tachycardia, it's really maybe not obvious that it's SVT. So by slowing down that rate, you can get a really good look at it and diagnose it. So we just said that adenosine will cause a flat line. Well, how's this better than tachycardia? The good news is that we've stopped your tachycardia. The bad news is that we've stopped your heart completely. You're welcome. Well, luckily adenosine is a very short-acting drug. It only lasts about 15 seconds. So a patient comes into the ER with tachycardia, maybe at 150, 160 beats per minute. You don't know what the rhythm is at this point, so you try a few things, maybe vagal maneuvers, carotid massage. If that doesn't work, then you might use adenosine. The patient is hooked up to the monitor. You should probably tell them that this is going to be uncomfortable, and don't forget to turn down the volume on the monitor. Patients tend to freak out a bit when they hear themselves flatline. So you push the adenosine, and basically the heart stops. So that kind of 5 to 10 second moment can seem like an eternity, just waiting for the heart to start back up. And when it does start back up, it's generally at a much slower rate. And then it gradually works itself back up to SVT in many cases. Now, in some cases, that adenosine is going to actually stop that SVT altogether and you're done. But at the very least, you have this window of a much slower heart rate where you can get a good ECG strip and where you can then analyze and then determine what type of rhythm that you're dealing with in that situation. Now, toxicity for adenosine includes flushing, hypotension, and chest pain. Another sneaky test question is that adenosine is blocked by another completely unrelated drug. The effects are blocked by theophylline. So who uses theophylline? Well, patients with COPD, really bad asthma, might use theophylline. It's really like a third-line drug at this point where you don't use it very often. So that's about it for adenosine. Couple little final things here, potassium, magnesium. Potassium depresses ectopic pacemakers in hypokalemia, so that's where you can use that. It's also commonly used in digoxin toxicity. Magnesium is effective in torsades and digoxin toxicity as well. Potassium and magnesium, when deficient, are highly correlated with arrhythmias, especially in patients that are predisposed to arrhythmias. Maybe someone who's already just had a heart attack, so watch out for magnesium and potassium in that situation. So patient comes in having an MI, always make sure their potassium is above 4, their magnesium is above 2. Because when those drop below 4 and 2, they are more likely to have arrhythmias because the MI is setting them up for that arrhythmia. So you want to make sure you're always looking at those electrolytes and making sure they're optimized to avoid those arrhythmias. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what is the mechanism of action of each class of antiarrhythmic? So the mnemonic here, no bad boy keeps clean, or maybe some block potassium channels. Choose which one you like. Class 1 are the sodium channel blockers. Class 2 are the beta blockers. Class 3 are the potassium channel blockers. Class 4 are the calcium channel blockers. Next, which antiarrhythmic has the side effect of synchronism? So remember, that's going to be quinidine. Next, what are the potential side effects of amiodarone use? So pulmonary fibrosis, hyper or hypothyroidism, hepatotoxicity, blue-gray skin discoloration, photodermatitis or photosensitivity. It can cause bradycardia, heart block, corneal deposits, neurological problems, and constipation. So a ton of stuff. Next, what is the mechanism of action of adenosine as an antiarrhythmic? So remember, adenosine increases the outward potassium current, causing hyperpolarization of cells and decreasing intracellular calcium, so it basically stops the heart. Next, to which class of antiarrhythmics do each of the following agents belong? So first we have sotalol. That can fool you. It's OLOL, but it's not a beta blocker. It's a potassium channel blocker, so it's classified as a class 3 antiarrhythmic. Propranolol is a beta blocker, so it's class 2. Beryllium is class 3. Quinidine is a class 1A. Verapamil is a calcium channel blocker, so it's class 4. Procainamide is a class 1A. Lidocaine class 1B. And diltiazem is another class 4. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.